here and make sure
Oh, sorry.
that comes through okay.
Yep, perfect.
All right. So it's really nice to have the opportunity to come and have a conversation about this topic that's been so important to me and my group over the past 15 years or so. And based on guidance from Katrin, my plan would be to spend about 20 minutes giving a summary of why I think heart health is especially important to people with bipolar disorder, including youth, not just from a physical health perspective, but from an emotional health perspective, from a research perspective, and from the perspective of the value that it brings to reducing stigma. And then after that, we can have a conversation, discuss questions or people's reactions to the slides. So I wrote, why it's extra important, because I think it's pretty self-evident that heart health is important to everybody, but I think it's extra important for people with bipolar disorder. I don't have any commercial interest to disclose. So I'll walk through these graphic slides just to kind of convey the rationale for including them here. What you're looking at is a bar chart from a large representative sample of the United States. So this is from a community-based study of over 40,000 people. And what we looked at was, what was the age of individuals who had bipolar disorder type 1 or type 2, as you see by BD1 and 2, or major depressive disorder, compared to people that don't have a mood disorder in terms of when they have a onset of heart disease. So this was a two-wave study separated by 3 years. And we looked at people that did not have a history of heart disease at the first wave, but by the time they came back 3 years later, they did. And what you can see here is that adults with bipolar disorder who have new onset of heart disease, on average, are 17 years younger than people that don't have mood disorders. And while this is not unique to bipolar disorder, as you can see, also people with major depressive disorder or unipolar depression, they too have higher rates of heart disease and earlier onset of heart disease, but the magnitude of this association seems to be especially strong in bipolar disorder. It's a big association in this study that I just showed you, and I think what's important about this study is because it's a population-based sample, many people were actually untreated for bipolar disorder. And because it was large, we could look at whether this association was explained by smoking, physical activity, nutrition, substance use disorders, etc. And even if you control for all those things, still there's this connection between bipolar and early heart disease and excessive rates of heart disease. It's nothing new, as it turns out. So Emil Kraepelin was a psychiatrist over 100 years ago. And at this time that he was in practice, there wasn't really any treatments as we have now. We still have limitations with our treatments, but we have some good treatments. And this preceded even lithium. And Dr. Kraepelin, therefore, was able to make observations of individuals with bipolar disorder, over 900 of them, that was independent of any sort of treatment in a different era when people were typically more physically active than they are these days. And what he observed was not at all infrequently, and in comparative youth, arteriosclerosis, or what we would call atherosclerosis, the cause or the main reason that people have heart disease, is present. So this is over 100 years, and there's even writings from Egyptian texts. And in fact, the Egyptians classified mood disorders not as conditions of the brain, but as conditions of the heart, which I find really interesting. All this to say, this is a long-standing connection. This is a picture of the first page of an article that we wrote about 7 years ago. This was published not in a psychiatric journal, but in a leading cardiology journal called Circulation. There had been a publication in that journal that established a number of conditions in young people that gave them increased risk for heart disease. And the idea is, if you can identify these additional risk conditions in youth and you treat them and you recognize that those youth have higher risk for heart disease, maybe you can prevent that increased risk that's connected with a condition. And what we did, a group of us, was add to that list of conditions bipolar disorder and major depressive disorder. So this was really a big opportunity to share with, not just the mental health world, but the medical world. And in fact, this publication got a lot of coverage in the media because it's not really a connection you think of. First of all, For most people, they may not know there's a bipolar or major depression heart connection, and certainly they wouldn't think of youth. And there is implications of it in terms of, which risk condition. As you can see, things like diabetes, which we expect to be related to heart disease, are called high risk or tier 1. And then we added the mood disorders to the moderate risk or tier 2. And what I think is important from a public health perspective is that, any kid that has these other conditions, kidney conditions, inflammation-related arthritis, cardiac diseases, such as those that are infectious or inflammatory, they all deserve extra care to their heart health, for sure. But if you look at the prevalence or the number of people in society that have mood disorders when they're young, it's 1 in 10. By the time they reach the end of adolescence, will have had a mood disorder. And so the impact of acknowledging this connection is especially large. The other thing is that in addition to having medical conditions, if you have, like bipolar disorder, if you have other cardiovascular risk factors, like 2 or more of this list, you can smoking, cholesterol problems, family history of early heart disease, etc., people that were in the middle group or the moderate risk would be bumped up to the high risk. So we looked at this in our clinic and found that almost 50% of teens with bipolar disorder would have 2 or more of these risk factors. So what that says is they should have their heart health addressed at a similar level of priority or importance as youth with diabetes. And I think this is really not a recognized connection. So you've heard that there's higher rates of heart disease earlier. What are the reasons for this, or what is the reason for this? And the way I approach it is that there's multiple potential reasons. So if you start on the left looking at biology, there's biological processes. Inflammation is probably the best example. Inflammation is something that can cause Crohn's disease or can cause inflammatory arthritis, but it's also been associated with bipolar disorder. Environmental factors are super important. So the ability of somebody to have a regular sleep routine, to exercise, have good nutrition, all of those things are important for heart health. In addition, if people have history of physical abuse or sexual abuse or other types of early trauma, that really sets people up for heart disease as well. And finally is the issue of medications, which are not known to cause heart disease per se, but some of them are known to increase heart disease risk factors. And the reason I put all of these in the same slide is that when we wonder why there's such a strong connection between bipolar and heart disease, it's because there are just so many factors that contribute to it. The silver lining to that, I think, is that each of these factors could be addressed by different individuals in a person's life. So a psychiatrist might look at one, a researcher might look at one, a parent or child or spouse might look at another, but anybody interested in the bipolar heart connection who has someone in their life with bipolar disorder that's important to them, there's something that they can do to facilitate reduced risk of heart disease in that person. So I'm a child and adolescent psychiatrist based at the University of Toronto and the Centre for Addiction and Mental Health, which is a leading psychiatric hospital in Toronto. And you may wonder why I've been talking about heart disease, but I think in addition to wanting my patients to live long and healthy lives, it's important to acknowledge that heart health is related to mental health. What you see in this slide is all the different things that have been connected with heart disease risk factors, and that could include obesity or cholesterol problems or blood pressure or a combination of those things. So what you can see in this slide is if a person has bipolar disorder, mostly these are adult studies, but there's also youth studies. If a person has bipolar disorder and has a heart disease risk factor, those individuals tend to have more mood episodes, more likely to get hospitalized, their functioning is lower. I've put stars or asterisks beside a number of these because they're replicated in youth as well as in adults, and in particular suicide attempts. So there's a connection between obesity and suicide attempts that's been observed in adults, in general community samples, in hospital-based samples, and the same is true for youth in hospital samples and in community samples. So we can't say that these things are caused by one another, right? We can't say that one causes the other, but we know that the association, it's not a one-off study. This is highly replicated. And it raises this question: what if we deliberately set out to improve people's physical health, not just to prevent early heart disease, but also to improve their here and now, or their short-term, their near-term mental health? I would say that so far this isn't something that people try. I want to present a couple of slides on some of the research related topics that I think are also relevant. So what you're looking at in this slide is, this was work done by my PhD student, Cody Kennedy. In middle-aged adults and in older adults, there's well-established connections between cholesterol and the structure of the brain. So people that have higher levels of the bad cholesterol or lower levels of good cholesterol tend to have smaller volumes or thickness of certain brain regions that are relevant to mental processes, cognitive processes, like memory and attention. And those findings are well established in middle-aged and older adults with or without bipolar disorder, even in the general population, but they've really never been examined in youth. In fact, to the best of my knowledge, this is the only study that's looked at cholesterol in relationship to brain structure in teenagers. And what Cody found was, if you look at the orange line and the orange dots, the higher a person's bad cholesterol, if you will, LDL, the smaller is the volume of their hippocampus, a region of the brain that's crucial for setting down and recording memory. And in the healthy control teens that didn't have a mood disorder, what you can see is that there was a direction, it went in the opposite direction. So the higher the cholesterol, the bigger the structure. So hard to say exactly why that was true in the healthy controls, but what I would say is that what we're seeing in this slide is a similar association as adults is evident in youth with bipolar disorder, probably premature in the sense that typically you wouldn't see this in a healthy teenager. So again, raising the question of, if we know that even within normal limits, so these cholesterol levels, you can see they're across the board from low to high. It's not that everybody has clinically high levels of cholesterol. Nonetheless, we see connections with brain structure, even in a teenager, meaning it's something that's important. The next question is what you can do about it. And I don't have any fancy answers to that. Rather, I'm really interested in the more obvious or straightforward answers that are harder to accomplish than they are to think about. And exercise is the best example of that. It's not hard to imagine how exercise could be a great intervention to address both the mental health needs and the physical health needs of people with bipolar disorder. What you see in this slide is there's a pediatrics questionnaire that we administered to our patients with bipolar disorder and healthy control teens, and they asked about different questions that relate to exercise. Working out was a question about how frequently people work out moderately or vigorously, so that's exercise where you would be breathing heavily or sweating. Working in, or other people would call it incidental physical activity, things like walking or gardening or household chores where you're moving, but not to the same extent as a workout. And then there's also benchmarks for sedentary, or, you know, in our lives these days, they're really built around sitting, a lot of sitting. And so there's benchmarks for how much people should be moving in general in a day, and or how much they should be sitting. So what you can see here is, you know, based on the fact that the best one was 50% reaching the recommended benchmark, that whether a teenager has bipolar disorder or doesn't, physical activity is not something that's super common in the current era. I think a variety of reasons for this, but where the teens with bipolar disorder separate themselves is that they particularly seem to avoid or not be able to tolerate moderate or vigorous physical activity, what we would call a workout. As you can see from the short blue column on the left side, only 1 in 20 teenagers in our clinic said that they exercised at least 4 times a week, which is the recommended minimal healthy living threshold. And as you can imagine from the earlier slides that I presented, I'm of the opinion that maybe teens with bipolar disorder could benefit from exceeding the minimum threshold, not just meeting it. And yet only 1 in 20 meet the minimum threshold that's recommended. So I think this speaks to the fact that there's a real unmet need to use an intervention that could potentially help heart health and mental health. In this slide, we did an exercise study, and it involved cycling on a stationary bicycle. And based on people's heart rate during this exercise session, we calculated an estimate of their aerobic fitness or cardiorespiratory fitness. And this slide shows the relationship between depression symptoms and aerobic fitness. And what you can see here is that in the teens with bipolar disorder, the lower their aerobic fitness, the higher their depression. Now, we don't know which direction the arrow goes. Does a depressed individual become less likely to exercise and in turn get less aerobically fit? Does low aerobic fitness actually cause depression? My own belief, although this was a cross-sectional study, is that both explanations are likely true. So a couple of facts about exercise, and this is true, I think, across the lifespan, is first of all, there's low rates of aerobic or cardiorespiratory exercise in people with bipolar disorder, youth included. There's multiple potential benefits. So there's heart health benefits. In fact, if there's one cardiovascular or heart disease risk factor that people modify that could benefit them the most, the American Heart Association put out a scientific statement saying that it looks like cardiorespiratory fitness or aerobic fitness is #1. So that's, pretty impressive, even above, losing weight or stopping smoking. Not to say that one should limit oneself, but I think that this is hope inspiring in the sense that you can really improve your heart health and your heart disease risk just by improving aerobic fitness without even necessarily losing weight. And as you can see in the next point, the benefits are within reach for the majority of people, and independent of whether they lose weight or not. In fact, the reason I think this is really an optimistic fact is that the people who have the most to gain from small benefits, even small benefits in their small improvements in their exercise capacity or their fitness, are the ones that are the most sedentary. So if you're already running, 5-mile races or cycling all the time, yes, there are some benefits to your heart that come from improving your fitness even further. The big benefits really come to those people who do not exercise at all. So this is a bridge between exercise and research. What you see in the bottom left corner are 3 social workers, therapists that work and research coordinators in our group, Vanessa, Danielle, and Jessica. And we got together, the therapist, myself, a handful of patients and parents from our clinic, and also a consumer advocacy representative. So someone from, I know that in the US, there's the Depression and Bipolar Support Alliance and NAMI. We have a local equivalent. And so a representative also joined us. And we just brainstormed what could an intervention for youth look like that set out to improve aerobic fitness. And what we came up with, not to say that it's the right thing or the wrong thing, there hasn't been a study, or at least when we conceived of this, there hadn't been a study of youth or adults with bipolar disorder where the primary goal was to improve aerobic fitness. And I find that really kind of sobering that's the case, because there's many studies on therapies, there's many studies on medicines, but not a single one, a randomized controlled trial or even a pilot study looking at specifically improving aerobic fitness. So what you see in blue are the key components of the study, and then in green are a la carte or optional aspects of this study, of this intervention. Psychoeducation is a piece of it, which means giving people the information they need to make the decisions that could benefit them, understanding the connection between bipolar and heart disease, understanding what it does to people's cognitive or mental capacities, to their mood, etc. The conceptual approach to the therapy was motivational enhancement. So it's the idea that you have to meet people where they are, but help encourage them to resolve their ambivalence or their mixed feelings. I think most people with bipolar disorder, like most people in the general population, know that exercising is likely healthy for them. It's not a knowledge deficit. It's more of how do you improve your motivation? How do you troubleshoot impasses or barriers to exercise? So the 3 social worker therapists, they focused a lot on that type of approach. They used weekly telephone calls as boosters to cover whatever material was covered in the session and encourage people to keep applying it. We used objective testing of aerobic fitness. So rather than just asking people questions, we also used 2 tests, and recumbent cycle exercise bicycle, and also a aerobic step test, both of which are validated, as well as questionnaire measures of activity and Fitbits. For people that wanted to, they had an exercise coach that was available to meet them in the community, to meet them at the hospital, to come to their gym. There was the option for family-focused sessions for those that wanted to, and also peer sessions. So just to summarize, another important topic, and I'm moving away from exercise now, but talking about one of the key factors that doesn't relate to medicine or doesn't relate to the disease itself as to why heart health is especially challenging in people with bipolar disorder, and that is disparities. If someone has a chart diagnosis or a known diagnosis of bipolar disorder, This is true for other types of serious mental illness as well, major depression, schizophrenia. There are so many gaps in terms of how they're treated from a heart health perspective. So there's disparities. Obviously, people with bipolar disorder are lagging behind in terms of every single step, from when they first go to the emergency department if they have chest pain, to the intensity of the interventions they get in the moment, to the type of follow-up they get at discharge, whether people are prescribing the medicines, the preventative medicines that they need to. So no matter how you look at it, people with bipolar disorder aren't getting the same level of treatment as people without bipolar disorder. The disparities are ubiquitous. They're everywhere. This is not just people that have HMOs, people that are in the VA, people that come from countries including Canada or the Netherlands, Scandinavia, that have universal healthcare. You see the same findings. So this isn't just a healthcare model issue, right? This isn't just U.S. healthcare. It's across the board, and it's across conditions. So it doesn't just relate to heart attacks, but to diabetes, to high blood pressure, to stroke, anything kind of vascular related. You see these disparities. So that's all kind of negative. What's the hope here? The hope is that there is data that if you equalize the quality of cardiovascular care, that would take a big chunk out of the excess cardiovascular mortality of bipolar disorder. So what can people do? I think whether they're patients, family members, treatment providers, they can know that the individual with bipolar disorder is less likely to get standard of care. And they can alert people to that fact and double check as to whether whatever screening is to be done should be done, whatever interventions, and maybe even informing their treatment provider of this connection between bipolar and heart disease. The reason I say that is that if someone has had a serious course, a severe course of bipolar disorder who's 50, their physician may be treating them as if they're 50, whereas their body or their blood vessel, their vascular risk is older than 50. And so I think the recognition that bipolar means you got to look extra carefully and be extra assertive has to happen. This isn't, this idea is not an invention of ours. This is a paper from a leading journal in psychiatry, multiple publications on this topic, just drawing attention to the connection between heart health, between physical health and major mental illness, and the importance of beginning as early in the course of the mental disorder as possible and building this into treatment models. And I would say that despite the fact that recognition is, in my opinion, clearly growing, we haven't seen the same action in terms of healthcare systems that respond to that connection. So I'll give you an example. If a teenager is 16 years old, lives in Toronto, has diabetes, goes to our children's hospital, they're going to get set up with a nutritionist, an exercise counselor, probably a psychologist, as well as their endocrinologist, so their diabetes expert. So I would call that Cadillac, right? That's not necessarily true at every hospital, but by and large, that's the type of care you get as a child or adolescent with diabetes. Take another 16-year-old, identical to the first one, but instead of diabetes has bipolar disorder. Most likely it won't be detected as such or be mistreated. If they do get treatment, it's likely going to be a prescription from a primary care provider. Maybe they'll see a psychiatrist. And for those who have exceptional healthcare coverage or financial means, they could get therapy as well. But there's no nutrition counseling. There's no exercise intervention that comes with diabetes, as it comes with diabetes. So you're seeing this disparity even early in life, which to me I think is an important challenge. So before I close, I just wanted to share some messages of hope. We have in our clinic, we have a wall of hope. We give these 6-inch by 6-inch acrylics to patients who want to, and they can write messages of hope to next patients that are coming into the clinic for the first time, maybe intimidated by the diagnosis or its treatment, maybe feeling they're the first people that have come through. And so we've got about 50 of these now displayed on our wall of hope. But what struck me was how not infrequently the theme of heart health came in. So what you can see here is one young person that wrote, keep growing, keep going, keep growing. And you see the hearts depicted, this one as well. And then one person who was inspired by the connection between our biological research and heart health with bipolar disorder. So all of this to say that, whereas I'm not sure what people's reaction is in hearing about this, maybe we'll talk about it in a second, but to some extent it's negative. There's a negative connection between bipolar and heart disease, but there's also a lot of silver lining, a lot of opportunity. not just to improve people's heart health, but to improve their mental health, and also to reduce the shame and the stigma that's often connected to bipolar disorder that I think comes from having it positioned as separate from physical health, which I don't think that they're separate in any way. This is our clinical research program, the Center for Youth Bipolar Disorder. This is our symbol and our motto. So the symbol is heart bipolar, and the explanation of it is that to us, the heart not only represents dedication and care, but it's a symbol that bipolar is linked to cardiovascular risk and affects mind, brain, and body. So it's really part of our therapies, part of our biological research, and ultimately, hopefully, part of our pharmacological research. Just wanted to acknowledge that whatever I presented that relates to our own research was on the strength of participation from patients and families, as well as funders. And we have this fabulous team that I wanted to highlight and thank. And with that, I am going to unshare my screen and invite people to comment, ask questions. Feel free to ask them verbally, unmute yourself, or to write it in the chat, and then I can read it out as people wish.
Does anyone have any questions?
Yes. One of the things I was thinking about while you were talking was the connection between our medications frequently causing obesity, causing a lot of weight gain, and other various physical problems, and wondered about how that fed into the heart health.
Yeah, it's such a fundamentally important question, Chris. And so I just want to start by acknowledging the reality of what you're saying. So there's no doubt that some of the best treatments for bipolar disorder, lithium included, cause meaningful weight gain in a subset of people. Different definitions are given, but I don't think we need to, I don't think anybody doubts that there's a bunch of psychiatric medicines that cause weight gain. For some people, they can either on their own trigger changes in blood sugar, cholesterol, or uncover earlier than they had to be some genetic or familial risk. So I think that there's absolute truth to the fact that a subset of psychiatric medicines used for the treatment of bipolar increase cardiovascular risk factors. That said, you can imagine, like I'm focusing on teenagers, if the whole story was medicine, it wouldn't be that interesting, and it wouldn't really change how people think about the disease, and it wouldn't really, I think, shift behavior. And I want to give a couple of answers for why I think that while we don't want to aggravate the cardiovascular risk of bipolar disorder, we also don't want to overly stigmatize our medicine. So the example I give is for cancer treatment, where, you know, if you go to a hospital and you see an oncology ward, like you'll see people that have lost their hair. There's other side effects of major interventions for other illnesses, and nobody kind of accosts their nurse or their doctor, because I think the difference is that there's a recognition that there's toxicity to that treatment, but it's way less than the toxicity of the untreated illness. And I'm not saying that bipolar is cancer, but I am saying that I think that there's an underestimation of how severe the illness is untreated relative to the side effects of the medicine. So what I'm saying is I think we need to treat people with the best medicines possible to help ensure that their mood is stable, and then manage the cardiovascular side effects. In terms of the connection between medicines and actual heart disease or actual stroke, that's much less clear. So I'll give you an example. There's a medicine called clozapine, which is not that commonly used in bipolar disorder, but sometimes is, often used in schizophrenia. And I would say that that's the worst medicine from a metabolic perspective, most likely to trigger diabetes, major weight gain, increases people's resting heart rate, it can cause heart problems. And so you'd think that that medicine would shorten life, right? Like, how could it not? It doesn't. So if you look at the best data that we have in adults with schizophrenia, the longer someone spent on clozapine, the more care there was to ensure they're on therapeutic doses, the longer they lived. And the people that didn't have that exposure or had intermittent exposure, they had shorter lives. So it's not, you can't say that one is causal, but what I'm saying is that what I believe to be the worst cardiovascular medicine in psychiatry seems to be connected with at least equal lifespan as to people that aren't on it. So
Right.
how can it be that it increases diabetes and weight and doesn't shorten life? I think that's a scientific question, but One more point on this topic, and then I'll leave it, because I just think it's probably in so many of our minds as we think about the topic. This connection is, as I mentioned, was seen before we had any medicine. It's seen, I think, most unfortunately in general population samples. That US data set that I talked about with 40,000 people, 90% of those people that had bipolar disorder never had a mood stabilizer. They either had antidepressants that are not particularly bad for heart health, or no pharmacological treatment. And it's in that group that the 17-year prematurity exists. So I think we can be confident that we want to minimize the risk of medicines, but that this is not the main story. So hopefully that wasn't over the top in terms of length. But
No, that's actually reasonable. I will pick a small fight with you over the use of cancer medicines as an example, because those, while they are not short-term use, they're medium-term use. We are stuck with, once we finally find a medication that works for us, we're stuck with it for life, pretty much.
We have an illness that people are often living with throughout life. And I think, death is a negative outcome. It's, maybe the worst negative outcome, but a life that is not reaching people's potential is also a negative outcome. It's not just bipolar. If you look at the burden of illness across the lifespan, across the world, it's all psychiatric conditions. Like if you, and this is third world, first world, in terms of disability, in terms of what conditions keep people from living their full life, getting in the way of their family function, work function, it's psychiatric illnesses. So I think that's important too. And if
no, I agree it should be treated, but I just don't think that it, the cancer medications, yes, they're toxic, but they really, I'm very frustrated with the types of medications that they have found to help with bipolar disorder, and because of the long-term nature of our involvement.
Yeah. No, this is a key problem that, and I think that it's not a fluke that some of our most effective medicines have this as a side effect. I'll just give you an example. So clozapine that I mentioned is, I said, the worst metabolic medicine that we use in bipolar disorder or major mental illness that's commonly used. So people obviously thought, okay, let's look at the molecule that is clozapine and let's find out what's the stuff that we need to keep to make the benefits, and can we cleave off those neurotransmitter, those receptors that aren't key to antipsychotic effect and that are just driving this diabetes and sedation and all this kind of stuff. So, designed a new molecule. I think the best example is ziprasidone or Zeldox. I can't remember if that's what it's called in the States, or Geodon.
Geodon, I've heard, yeah.
Geodon. Yeah, so what happened was it was a much more tolerated medicine and it's much less effective. So there's something about taking away the whole picture that made it not as potent. I agree with you. I wish we had better answers and medicines that didn't do.
Yeah, thank you.
Yeah.
Does anyone else have a question?
Maybe if there's, I'll just throw another factoid in about the exercise topic. So one of the things I try to do when talking about exercise is just to totally disconnect it from weight. Like I don't think that's it's not commonly a fruitful reason to exercise. I think people get discouraged because there's so many factors that control weight. With people with bipolar disorder, it's even more, because they're more likely to have depression, have medicines that are sedating. So if you have the only sign of success of exercise to be weight loss, that's a bit of a bummer. I think there's a lot of other benefits. So that's one comment I wanted to make about exercise. Another comment is that people with bipolar disorder or other mental illnesses are often told by their friends or their relatives, just exercise, just try it once, you'll feel great, you'll get a buzz. And what we found in a study with youth, and this is 50 teens with bipolar disorder, we had them look at their mood before and after a single session of 30 minutes of exercise. And they also did brain imaging before and after the exercise. And we were looking at how blood flow changed. And what we found was that teens with bipolar disorder had different patterns of blood flow before exercise. but that after exercise, that single session temporarily reduced the difference to the point that they weren't significant. So let's just call that normalizing. We looked at the subjective experience of exercise in people as a function of their blood flow changes. And what we found was those teens with bipolar whose blood flow in their brain most normalized were the ones that felt the worst physically, most exhausted after exercise. So it's kind of the opposite what we would expect and what we would advertise, that the person whose blood flow in their brain got the best was the same one that had a real buzz from exercise, and it wasn't the case. So when I hear clinically now that people say, well, I did try it and I felt lousy, I'm much less likely to look at that sideways or to dismiss it. I think that there's a biological basis to that, and I try to normalize that or educate people about it, that I don't think it's forever. I think that at some point there will be a day where people with bipolar disorder who haven't been exercising get used to the exercise and they do get that good feeling. But it's not always the case that they will have that good feeling. And so if they're expecting that as a sign that they're doing something healthy, it may be a while coming. I don't know if people have their own experience with hearing input from others in their lives or from doctors, but I think sometimes people are disappointed that it doesn't do what other people would describe it to do for them. Okay, I'll just go to the chat here and
I think one of the good questions is, how do you approach your primary care physician about the risk of diabetes, high blood pressure? Because sometimes they don't know much about these medications that we're on.
yeah. I think the first thing is to know themselves that there's an increased risk, and to be aware of whatever is supposed to happen based on someone's age or based on someone's medical conditions, so that they can advocate for themselves. I think that bringing to a practitioner's attention that, oh, you know what, I've come to learn that bipolar is connected with increased heart disease risk, and I just wanted to make sure, like, are we looking at my heart health assertively, like what kind of screening should I be doing? But just letting them know that. The article that I mentioned is publicly available. I think it's always a little bit fraught to walk into an appointment carrying an article, but it's legitimate, right? This is from the American Heart Association. It's a real thing. So I think having that conversation, asking about how that would have implications in terms of monitoring, in terms of the thresholds for intervening, whether that be prescription or otherwise. I'm just going to look through other questions. I have no energy with meds. Yeah, I think that's two main things that we face daily in terms of helping people exercise more is energy, yes, and depression, which are interconnected. But sometimes people, even if they do have the energy, they don't have that buzz or that enjoyment. And so I think any strategy to exercise has to embrace that, at least in the short term. I would say that, not to oversimplify it, but the lack of energy, I think, is intertwined with lack of exercise, and sometimes it's like any other sort of physical condition that's related to lack of exercise, where it may be uncomfortable at the beginning. Over time, it should improve for most people. Lithium and cardiovascular health. So if there's one medicine that's related to reducing the burden of heart disease and bipolar disorder, now these aren't clinical trials, they're observational studies, but if there's one medicine that has the clearest evidence, it is lithium. Elevated blood pressure. Yeah, in terms of blood pressure, heart rate, not so much for most of these things, but blood pressure for some medicines, it goes up, but so does, people, there's old studies from 100 years ago of people's blood pressure and heart rate during mania, during depression, without any medicines existing at the time. And already, this is in Kraepelin's 100-year-old text, as people cycle in their mood, they cycle in their cardiovascular health. And that was true over 100 years ago. Clozapine is different than clonazepam. Clozapine is an antipsychotic. Clonazepam is a benzodiazepine like Valium or Ativan. So they're different. They're both sedating, but they're otherwise quite different. Exercise. when I became manic. So, the connection between exercise and mania comes up often. People ask the question, like, what if it makes you manic? My answer to that is I don't think we have clinical trials to answer the question, but as someone who's been practicing psychiatry for close to 20 years, I've never heard of someone coming to the emergency department with exercise-induced mania. You see that commonly for long-distance travel across time zones, for cannabis, for major stressful life events, positive or negative, but I've never seen a case, although cases exist. So I'm sure that it may be the case for some people that exercise can trigger a manic episode. I just think it's very uncommon. I find that one of the earliest things people do as they become manic is start moving around more and exercising. So in those cases where I have seen people exercising a lot, it's generally been the case that it's to blow off that energy from mania. But I can't dismiss the possibility. I just think on balance of risk, I think it's pretty unlikely. I would say for someone who's not manic, and trying to prevent the activating effects of exercise, it may be a good idea to do it earlier in the morning or midday and not right before sleep, because it could be disruptive. Is it true that lithium can induce diabetes insipidus? Diabetes insipidus, although it's a similar word to diabetes mellitus, is different. It's not related to sugar. It's related to passing more water in the urine than the kidneys would otherwise do. And yes, it does cause that. It's just a description of producing more water in the urine, and it just means that it's important to hydrate. It's not by itself dangerous. Would weight loss surgery help lose weight? This is a big topic. I have a colleague, there's bariatric or weight loss surgery programs, very, very effective in many populations. It depends on the service, on the clinic, but oftentimes untreated or unstable psychiatric disorders are ruled out, meaning you can't do it. And the reason for that is it can be difficult to manage the requirements of weight loss surgery. I think there have been some reports of people, when you literally block the body's attempts at, I would say, not everyone who overeats with bipolar disorder is self-medicating, but I think a fair number of people are self-medicating. If you physically block that, there is the possibility that you prevent the person from treating something. And so there's case reports, I don't know exactly how strong the literature is, but people that stop overeating and develop addictions, or stop overeating and become suicidal. So these are individual level conversations to have. What I would say is that at the general population level, weight loss surgery seems to be quite effective, although I'm not an expert in it. These are all great questions. Let's go back to the chat here. Yeah, so I think the comment about exercising more and maybe not, once someone's manic enough to be exercising all the time, they may not be aware of themselves as manic and just have this feeling of energy. What can I say? I've seen that happen a lot. Happy to answer questions that extend beyond the scope, like of our conversation today. If anyone has questions about youth bipolar, about treatment, or anything like that, happy to do that too.
Any questions? Any questions about early onset bipolar?
Yes. What are you finding at the earliest age of you seeing bipolar show up?
So let's start with what's common. Super common is 15, 16, 17. I think that the average age of onset of bipolar on average is 18 to 20. So you're going to see a lot of people that have it in their middle adolescence. And then I think that the frequency of it goes down pretty steeply after that. So going from 17 to 13, it's much lower in 13-year-olds. This is from US data. We don't have good data on pre-13. So what I would say about that is there's a lot of controversy about childhood bipolar disorder, that I sincerely think that it exists. I think I've seen young individuals, 10 years old, that have had mania. I just think that it's relatively uncommon. So it kind of depends. Is it possible? Yes. Is it frequent? No. If you have a clinician who has many 6-year-olds with bipolar disorder. I think that is a cause for a little bit of double checking because you want a second opinion in those types of cases. The youngest case I ever saw in my career was 5 years old, and I remember thinking like it was just kind of hard to square the symptoms being read out of a textbook with the fact this was a preschooler. And I always wondered what happened to that person. I had followed them clinically in Pittsburgh when I used to work there for about 6 months or a year, and then they dropped out of care. And I would present the case of that 5-year-old to residents when I was teaching, and they would always ask the question because even those who are skeptical, appropriately skeptical, when presented with that case, would be quite impressed with how much it looked like bipolar disorder. I didn't know what happened, but then subsequently that young individual came back into care as a university student and was under the care of a colleague of mine. And so I know that the 5-year-old who had bipolar disorder turned into a 20-something that had bipolar disorder. I'm not saying that's common, but I think that that it exists. And just because I like analogies to other medical conditions or metaphors, kids can have, unfortunately, strokes. They can have pediatric tumors. They can have multiple sclerosis. These things aren't common in kids, but they can happen. So if we really think bipolar is a real condition and brain-based, then theoretically it should be able to happen.
What would you say to researchers like Dr. Jin Mali at Bipolar Disorders Journal, who don't think that early onset bipolar disorder should be a valid diagnosis?
Yeah. What can I say? That's been a hard pattern to watch, as you can imagine. There's various debates in the literature. A group of us have written answers to that sort of thing. I think when people have beliefs that are based on feeling, I think that they are able to dismiss. This is a bias. So I would say that someone that would say that it's impossible for a child to have bipolar disorder, I sincerely believe that to be a bias. And I wrote this in an article. Let's agree on this. Bipolar is brain-based. Children have brains. So why wouldn't children be able to have bipolar disorder? I can understand if someone had 20% of their clinic with 5-year-olds with bipolar disorder, that people would be skeptical, but the idea that it can't exist, and it's just hard to get around the fact that there's still this conversation about existence. Like, we should really be talking about prevalence, about the frequency in society, about how do you separate it. But yeah, it's been daunting. I think that I was drawn to this field in 2004 at a time when it was just starting and super controversial. And we've seen so many of the controversies calm down with data, with information, with large samples. But then there's still a subset of people where like no amount of data will be enough. So there, I really try to partner with patients and families. And I think that in response to one of the letters you're mentioning from that individual, there was, I think, 3 patients with lived experience that wrote a much more strongly worded article than I would be comfortable writing. And I was so happy to see it.
Yeah, that was actually me.
Oh my God, I'm really happy to hear about that. Like, we tried to get some people together to write something like that, and we weren't able to do it. So I'm just so glad. I think that was such an impactful act on your part. So thank you.
Thank you. Any more questions?
I am so delighted to see that it actually hit the mark, that your work really made a difference.
Thank you.
What can you say? I think when people start getting in an echo chamber and they're always hanging around professors or doctors, like, you forget that what's at stake here, what we're talking about. Like, so I think that so important. And again, one more analogy just to end off. Like, if you look at Autism Speaks, if you look at HIV, if you look at cancer, there's been so many advances that have benefited from the collaboration of researchers, clinicians, and people with lived experience. We haven't done as well in mood disorders, and I think that if we did, that's a whole other boost that can come to our field that we don't yet have. So that's awesome.
Thank you, Dr. Goldstein, for being with us today.
This was really a lot of fun, and I appreciate all the interest in the questions, and wish people all the best. Thanks, Katrin.
Thank you. Have a good day.
Thank you so much.
Thank you so much.
My pleasure. My pleasure.
Bye. Bye, guys.